Mitral valve connects left atrium and left ventricle. The mitral valve opens during diastole to allow the blood flow from left atrium to left ventricle. During ventricular systole, the mitral valve closes. It prevents backflow of the blood to the left atrium. Heart valves have a special property to prevent the backflow of blood. If mitral valve is not functioning well, blood can leak from left ventricle to the left atrium, which is called mitral regurgitation. Disruption in any part of the mitral valve apparatus can cause mitral regurgitation. It means any pathology of mitral annulus or anterior and posterior mitral reflex or chordotendency or papillary muscles or sometimes abnormalities of myocardium can cause mitral regurgitation. Now let's talk about causes of mitral regurgitation. Clinically, mitral regurgitation is divided into acute and chronic mitral regurgitation. Acute mitral regurgitation is due to myocardial infarction, or sometimes in infective endocarditis, patient may present with acute mitral regurgitation. Other cause of acute mitral regurgitation is blunt chest trauma. You can memorize causes of acute mitral regurgitation by mnemonics BIM. B stands for blunt chest trauma, I for infective endocarditis, and M for myocardial infarction. Now let's talk about chronic mitral regurgitation. Chronic mitral regurgitation is caused by rheumatic heart disease, extensive mitral annular calcification, congenital valve defect, hypertrophic obstructive cardiomyopathy, dilated cardiomyopathy, connective tissue diseases like Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta. You can memorize the cause of chronic mitral regurgitation by mnemonics chronic dilated cardiomyopathy. It stands for annular calcification, congenital valve defects, connective tissue diseases like Marfan syndrome, Ehlers-Danlos syndrome, and osteogenesis imperfecta. H stands for hypertrophic obstructive cardiomyopathy, R for rheumatic heart disease, and dilated cardiomyopathy is another cause of chronic mitral regurgitation. So now let's talk about pathophysiology and clinical features of mitral regurgitation. First, we will discuss about acute mitral regurgitation. In acute mitral regurgitation, heart does not get enough time for compensation. So, in acute mitral regurgitation, blood regurgitates from left ventricle to left atrium rapidly. So, in acute mitral regurgitation, there is sudden increase in pressure of blood in left atrium, which later shifted to lungs, causing pulmonary edema. So, in acute mitral regurgitation, patient present with rapid onset of significant shortness of breath, which may lead quickly to respiratory failure. Now in next cycle, that regurgitated blood should go to left ventricle. It means in next cycle, left ventricle receives more blood. Left ventricle try to pump that extra volume of blood by increasing the heart rate and contractility. Even after this compensation, if heart cannot maintain adequate cardiac output, patient may develop hypotension and cardiogenic shock. So, in acute mitral regurgitation, patient either present with pulmonary edema or cardiogenic shock. But this scenario is different in case of chronic mitral regurgitation. Patient may remain asymptomatic for long time. Patient present with symptoms of volume overload. Volume overload causes left atrium to dilate. Left atrial dilatation predisposes patient to atrial fibrillation, and patient may present with palpitation. Initially, left atrium undergoes dilatation, but in later course of time, left ventricle undergoes dilatation and hypertrophy. Due to structural change of left ventricle in long time, heart cannot maintain ejection fraction, which leads to fall in cardiac output. Now back pressure to the lungs causes pulmonary edema. To prevent pulmonary edema, pulmonary vessels undergoes vasoconstriction. Chronic vasoconstriction leads to pulmonary artery hypertension. Finally, pulmonary artery hypertension causes right heart failure. So passage of chronic mitral regurgitation ultimately leads to congestive heart failure. So now let's talk about signs of mitral regurgitation. Patient may present with tachypnea, with respiratory distress due to pulmonary edema. Patient may present with tachycardia. Patient may present with pansystolic murmur. You can hear pansystolic murmur best at apex beat. And you can hear murmur during entire systole. That is, from S1 to S2, you can hear pansystolic murmur. Pansystolic murmur of mitral regurgitation often radiates to axilla. If the cause of mitral regurgitation is mitral valve prolapse, you can hear mid-systolic click before the murmur in case of mitral regurgitation. So now let's talk about heart sound. In mitral regurgitation, S1 will be soft. You should remember, in case of mitral stenosis, S1 will be loud. But in case of mitral regurgitation, S1 will be soft. There will be wide splitting of S2. Wide splitting of S2 is due to early closure of aortic valve. As the blood is leaking from left ventricle to left atrium, so the aortic valve closes earlier. So there will be wide splitting of S2. Some patients may present with signs of congestive heart failure like lower limb edema, increased JVP, and crackles, etc. So now let's talk about investigations of mitral regurgitation. The best initial test for all valvular heart disease is echocardiography. But when we talk about most accurate test in valvular heart disease, we should say cardiac catheterization. Cardiac catheterization is most accurate test for valvular heart disease. But best initial test in valvular heart disease is echocardiography. Through echocardiography, you can see the valve anatomy. You can see left atrial and left ventricular dilatation. ECG of mitral regurgitation patient may show left ventricular hypertrophy and left atrial enlargement. Chest X-ray. Chest X-ray of mitral regurgitation patient shows cardiomegaly. Normally, cardiothoracic ratio is 0.5. In mitral regurgitation, cardiothoracic ratio may increase. You can also see vascular congestion in lungs in case of mitral regurgitation. Treatment of mitral regurgitation. Mitral regurgitation is managed medically and surgically. AC inhibitors, ARBs, and hydrolyzins are used. They increase cardiac output and reduce pulmonary congestion. Anticoagulants are used for reducing the risk of a stroke in case of atrial fibrillation. Diuretics and digitalis are also used. Sometimes mitral valve defects is corrected percutaneously, but in some cases surgical management is needed. Surgical management is by valvoplasty or valvotomy. Indications of surgical treatment. In case of symptomatic patient, surgical management may be needed. Anyone present with significant limiting symptoms and severe regurgitation is managed through surgical approach. In case of asymptomatic patient, if ejection fraction is less than 60% or left ventricular end systolic diameter is above 45 mm, this patient can be managed through surgical approach. So you should remember, if the ejection fraction is less than 60% or left ventricular end systolic diameter is more than 45 mm, this is the indication for surgery in asymptomatic patient. Two types of the operation is done in case of mitral regurgitation. One is valve repair, which is called mitral valvoplasty. Another is valve replacement, which is called mitral valvotomy. The choice of the patient for mitral valvotomy and mitral valvoplasty is based on clinical condition of patient and underlying etiology. Sometimes maze operation is also done in case of mitral regurgitation. Maze operation is done for atrial fibrillation. In maze operation, a scar tissue is created in heart. It prevents atrial fibrillation. So friends, this much for today. Thanks for watching this video till the end. For more videos, don't forget to subscribe our channel. If you like this video, please like it and share it with your friends. Thanks for watching. Thank you.